This is a Broken Reel Media production, and you're listening to the Something's Wrong Here podcast. I am Randy.
I'm Ken-Zee.
And a doctor is in the house tonight. Welcome to the studio, Brett.
Thank you guys for having me. Very excited to be here.
Yes, sir.
Tell us about yourself.
I'm a physical therapist up at Modern Physical Therapy in North Kansas City. Originally from Lee Summit here in town. Grew up here, went to high school here, went to college at the University of Arkansas, undergraduate degree down there, and then ended up staying, did my master's degree in exercise physiology after that. After all of that, working down there, ended up going to physical therapy school at University of St. Augustine for health sciences in Austin, Texas. And then upon graduating there, went to worked at a facility in Fort Worth, Texas. Worked there about 2 years, have been working on a fellowship program in outpatient physical manual therapy, and then recently moved back to Kansas City. Well, not as recently, back in 2019. Worked at a couple different companies, but then have settled up in North Kansas City.
What was that like coming back right before COVID? Did that affect your practice any?
Yeah, it affected it quite a bit. A lot of things happened professionally and from different clinics that I worked at, but it definitely changes a lot of things, going from normal society to the shutdown where, limited interaction, wearing the mask all the time, especially in a career like physical therapy where it's not in the hospital setting, but it's still one of the necessary fields to be in, but also being in a career where you're very hands-on, like around people all the time. So trying to maintain space and maintain that integrity during the pandemic.
So from 6 feet away, if you could just grab your leg and put it over your shoulder. Yep. You're doing it right.
That was kind of one of the stipulations or the challenges of what do you do? How do you approach this? Being in healthcare, you kind of have to be next to somebody. And so, it's definitely more about patient education at that point of hey, if you feel sick, please do not come in and go get tested. But you'd be amazed how many people still just came in the door sick.
Well, I would imagine physical therapy isn't kind of like the teledoc where you can just call, hey, I got a sniffle. Can you send me some antibiotics? It's a little more hands-on, face-to-face.
Yeah, and there was a lot of clinics nationwide that were going to more of a telehealth appointment process, which can be beneficial in some circumstances, but it's kind of hard. You can only do so much via telehealth and physical therapy. I feel I know there's a lot of people who do it as a full-time career, and they do great, but it's also, I'm a very hands-on therapist of trying to work with people to get their body to move better, and so for me, that was a huge challenge.
Or what can you do? Just tell them, hey, do these exercises, stretch this, do this, send them a plan. Yeah. And that's about all you could really do over the phone, isn't it?
Oh, that's not true. I'll jump in and I'll save him on this one. He could tell you what to do with a tennis ball and where to put it on your body in a door jam, and he can work out wonders with a tennis ball over the phone with you, man. Or a racquetball. Racquetballs, I think, is actually preferred.
Racquetball, cut a slit, pack it with Vaseline, good to go?
No.
Oh, no. That's not what you're talking about?
No, racquetball in the door jam, up in the shoulder right here. And by the way, if you're still doing that MR340 there, big dog, you might want to listen up. Door jam, racquetball or tennis ball, just wedge that bitch in and roll it.
I'll tell you what works really good too is a lacrosse ball. That thing is dense.
That's what it was actually.
Lacrosse
ball. Anywho, it was about that size, and you put it in a door jam, and even if it is a tennis ball, it works.
So. And when we say door jam, we're actually talking about a door jam, not some secret code for other parts of your body.
Okay, Randy, you have definitely taken this down a path. We're going to go a different path.
So what's wrong with doctors and physical therapy?
Yeah, with that resume you gave us. Mm-hmm. It sounds like a lot of school, man.
It is a lot of school, yeah. Kind of a quick history, just to let you guys know, because physical therapy specifically has evolved a lot. So it went from an associate's degree to a bachelor's degree to a master's degree, and then I have to go back and look at the years, but I think early 2000s it was required to have a doctorate degree at that point in time. So now everybody who's graduating has to have a doctorate degree.
Based off some things that I'm sure we'll come back to later, I think you do have to be a doctor to legally put your finger in someone's butthole.
If we're talking about the internal coccyx manipulation, then you don't necessarily have to be have the doctorate, but you have to. If you were grandfathered with your master's, you can do that.
But I think that you're supposed to be a doctor to do anything internal.
I think if you pay a prostitute enough, you can get that.
Okay, well, we're going to go back.
No, but I do want to say that, so a few minutes ago, I did learn for the first time that you can adjust the coccyx internally, as you told me. So, just a finger in, a push up, and a pop, and supposedly it's back in place, huh?
If the coccyx bone, which for everybody listening, if they don't know, is technically your tailbone, it's a very small bone at the base of your sacrum. And a lot of people, when they fall, if they fall straight down, that bone can become dislocated, or it can kind of adjust to an angle that's not normal, and that can create pain because there are muscle attachments. And there are external techniques where you don't have to insert your finger through the anus, but there is a technique where you can insert the finger through the anus, grasp on the other side, and then do a manipulation. Again,
I love how professional he was with the anus and coccyx, and he phrased everything so professionally.
Now, tell us about the weaklings, who are the largest demographic of who you see do this to.
Again, personally, I don't do this. Man, you try to throw me on the bus here.
All right, sorry.
Ken-Zee.
People in your profession.
Yeah.
So I had a professor who discussed this when we were learning about said technique. He worked specifically with bull riders, which would make sense, or even I would imagine even like bucking broncos, saddle riders. It's a lot of motion where there's a lot of slamming down, and he said that he would regularly have to do some type of coccyx manipulation. Yeah, it's pretty fascinating, actually.
I did not know that.
Riding the bull. Well, with all that school, we'll see if we can replicate a question that I've asked you before here. Would you do it again?
I think the first time I answered that question, I said absolutely not. And I would definitely go back and say I would only do it if I could do it a different way. Yeah. If I could go back and do it a different way than what I did.
Care to elaborate?
Yeah. One of the biggest issues that we're running into in the physical therapy world for professionals graduating is the cost of what schools, the cost of school, the cost of education. And not just physical therapy school. I know there's a lot of other professions out there, just med school and schools in general. But the cost of physical therapy school is can be outrageous. And especially in a field where depends on which setting you work in after you graduate, the pay scale, it is crazy. It's a crazy range.
So out of curiosity, if you were to throw the average of like what you think doctor of PT schooling versus average doctor of PT coming out, what are we talking about with like a delta number wise here?
So probably I think I have to go back and look at averages.
Shot from the hip. I'm not holding you to fire here. There's no expertise.
Probably average across the field. Most people are graduating with a student debt of over 100,000, and that's pretty common. That's actually very common based on school where you go, in-state, out-of-state, private schools, public schools. Obviously, public schools will be less expensive, especially if you're in-state. But then, probably average salary across the board, you're probably looking at 80 to 85,000 a year. Again, based on setting. I know certain settings pay a lot more and other settings pay a lot less, but I would probably imagine across the board your salary is looking around 80 to 85,000.
Okay, fair enough.
And has that dropped through the years, or has it stayed pretty consistent?
With the pay scale of what other PTs actually make, it probably has actually stayed probably fairly consistent. Again, based on type of setting, outpatient versus inpatient versus like a skilled nursing versus a skilled rehab facility. But cost of school has gone up dramatically.
I was just about to say, we all know that the cost of school, cost of living, cost of everything has gone up, and it just doesn't seem like the cost of what everybody's getting paid is keeping up.
Yeah, and that's kind of one of the big things that's really has kind of been the big factor for a lot of PTs specifically. So
fair. What going back, what else would you do differently? I mean, I know that we started that off and diving right into education. There's how much schooling, how much debt, etc. What would you navigate differently?
Yeah, I was very happy with the school I went to, and I've made great friends there. But looking back, I would definitely probably end up finding a route where I could go to an in-state school, a public institution versus a private school. If you have the means to go, then obviously it doesn't matter. But for me, I ended up going to a private school in a different state, and at that point in time, out of state, there is no in-state, out of state. It's just private, and it's crazy expensive. I know some other PTs who went to a public school out of state, and their costs were similar to mine going to a private school. So I would have gone back and made sure that I was living in a state that had probably multiple schools with multiple chances to get into a school, since it's so competitive, to get in-state tuition. So
yeah. One of the best things for me was going to a junior college. I mean, I got to graduate from there, had an associate's no matter what. I mean, I know a lot of people that went to get their bachelor's, went 3 years and then dropped out. They didn't have an associate's, didn't have anything to show for it. Plus, it kept the cost down. So that was one of the best things I could have ever done. How many years does it take? Did you have to go? You said that it went from, associates to a bachelor's. When you graduated, what was the...
Yeah, so when I did my schooling, it was a doctorate degree, doctoral program.
Oh, so you did have to have the doctorate by the time you graduated.
Yep. So for me, most PT school, what you have to do is you have to get some type of undergraduate degree. Now, the funny thing is that the undergraduate degree actually really doesn't matter. It doesn't matter what type of undergraduate degree you get. You just have to have
Isn't that crazy how that works out?
a bachelor's degree.
So stupid. If they just started you on the right program from the very get-go, it probably could have cut out 2 to 4 years.
And there are actually programs out there too that do something like that. I know Missouri State has a program where, and I think they still have it, where if you get accepted into it, you go into, it's a 6-year program instead of what typically is a 7-year, 7-year program. And it combines your undergraduate and you go right into physical therapy school right after. There is no waiting process. There's no other application process. Once you get accepted into it, you start your undergraduate degree, and then you finish that. I think you usually finish that within 3 years, and you go right into PT school right after that.
They've got that for a few other disciplines as well. I know pharmacy is one of them. So, speaking of doing different on the education route, is there an increase in the program length, do you think, due to, is it schools wanting money, or is there that much more tech and knowledge and of the body, etc.? Because I know both are probably true. Throw it at me here.
Yeah, actually, you kind of hit on the head with both. The field itself is growing like crazy. What we know about the human body, pretty much it seems like there's something more new that comes out within 5 to 10 years, right? We know more and more. The field of physical therapy has changed substantially in the last 20 years. And it's completely different than it was 30 years ago. Back in the 90s, when people would go to therapy, they would go in and they would get electrical stimulation, maybe get like some soft tissue mobilization or a massage, basically.
Get the band shaker.
Yeah, the old machine out there. And then they would do a lot of that. They would maybe do some ice, some heat, maybe a little bit of stretching, and then they would just put you on electrical stimulation, where we know so much more about recovery process. Yeah. The example I give to most people is look at sports science and how athletes train and how they recover. It's so much more advanced now than it was back when Jordan played. So we know so much more. So the demand to have that knowledge to get people to recover better and get out of pain or post-surgical rehab is so much more advanced. We know so much more than we did. So therefore, we need more education on kind of how we're going to do it. The field of physical therapy also wanted to have a little bit more autonomy on how we treat patients versus just having people come in and put them on E-stim. But then also too, I mean, as we all know, schools are also kind of like a business. They're trying to make money to pay their educators, to keep the doors open, to pay their board of trustees, to all that kind of stuff too. So
they got to afford the yacht somehow.
So it's really kind of a combo of both.
Yeah.
So
we brought up ice baths. That seems to be the new trend now. Everybody's buying ice baths. Benefits? They worth it? Not worth it?
Yeah, there is a lot of benefits to it. It can, help with any type of swelling, inflammation. We all know ice is a vasoconstrictor, right? So it limits the amount of blood flow, which can reduce the amount of swelling.
Okay.
So that's pretty common knowledge. There's a lot of research out there about ice baths that are coming out with like recovery process and like inflammatory proteins, as well as I think, and one of my coworkers is way better at this than I am with ice baths because he takes cold showers all the time. But there's all kinds of protocols, and who has the best protocol, who knows? But there is something to it. I don't know. I would do one every day personally, but there is research on there. 3 to 4 times a week can really help. Same thing with saunas too, with kind of to add that on the opposite end of it with that exposure to heat. There's some of that with like cancer cell research and things like that. So
interesting. Well, growing up as an athlete, I was always told ice, heat, ice, heat, ice, heat. Is it good to rotate like that, or have we changed our thought process on that?
Yeah, so I think there's a little bit of a change. We know in the first 24 to 48 hours, ice is really great to kind of help limit some swelling. Now, the other thing too is you actually want swelling because it's the body's natural way to kind of bring in proteins and properties to help with healing. Okay. But you also don't need an excess amount of swelling. But then anything after that, really the research is all over the place. It's like 50-50. So what I always tell my patients is, what do you like best? If you're not if you're not right after surgery and you're not post-injury, what do you like best? And most of the time they like heat or they like ice. And I say, great, just use that. And then they'll I like to cycle between the two. Great, do that. Because the research doesn't tell us anything really. It's just more preference.
I love how you... The research doesn't tell us shit. That's amazing.
We could probably go pull like 50 articles that says heat's better. We could go probably pull 50 articles that says ice is better.
So
speaking of that,
that's perfect.
Is ibuprofen, does it work?
Wait, what did you just say?
Ibuprofen.
Ibuprofen?
Ibuprofen.
I mean, just say it like a normal American. Ibuprofen.
In his defense, he's saying it how it's
I
spelled.
know he's saying how
it's like
spelled.
when you say Wednesday instead of Wednesday.
But does anyone say Wednesday?
I don't know if I've ever heard anybody actually say ibuprofen. I don't know.
I hope you get pneumonia.
Ibuprofen? Pneumonia?
All right.
Is ibuprofen actually worth it? Because I know I take it all the time and it doesn't seem like it does shit.
It can help as long as you use it for the correct thing, which most people hate when I say this because we hated this in school. It depends. So it depends on what you're taking it for. If it's like, if there's a little bit of swelling, yeah, it can help. If there's a little bit of pain coming from the joint, maybe the muscle, absolutely. If there's pain coming from the nerve, probably not. It's not going to do anything.
Fair to say Randy's using it wrong. He can't even say it right. So go back a step because this got weird for me for a second. You just said the research doesn't show us anything because you can find 50 hot, you can find 50 cold, whatever, you can find 50 alternating. What work through that with me, make that make sense. I don't even know how to frame this question, but like, is there actually something to one of them? Is there something to the other one? Like, how are we so across this board and not in agreement at this point with what we have in technology?
Yeah. So the beauty of research, right, is to figure out, does something work? Does it not work? Is it going to help? Is it not going to help? And, with research, you have to create a question. And then with that question, you have to have all these variables you have to control. Unless you do an outside setting, then you have to account for all those variables. But with that, sometimes we don't always get the answer that we want out of it. So for the ice heat debate, again, so ice is a vasoconstrictor, which means it's going to limit the amount of blood flow, which means it'll limit how much fluid can get, say you sprain your ankle, how much fluid can get to the ankle. So that way it's going to help control swelling. Now, for example, too, heat is a vasodilator, which means it's going to increase blood flow, and it can kind of keep things more loose because the tissue has more mobility because tissue has elasticity to it. So, for example, my rotator cuff patients, after they have surgery, when they come in, the first thing I do is put a heat pack on them to get blood flow to the area to help promote healing, to bring all of those properties that the blood has to naturally heal the body. And then it kind of loosens up the tissue to allow people to kind of move better. Because, if you've ever been in an ice bath and you get out of it and you just go, oh man,
everything hurts and it's tight.
It's tight, it's stiff. But then say you go in a sauna and you come out of that and you're just like, man, I feel great. Like you can move everywhere. You do a squat, your hips actually move a little bit. You know, there's no creakiness to it because there's increased blood flow to the area, and the tissue that has the elasticity can actually kind of relax and loosen. It's kind of like a rubber band. We use that an example at work is you put a rubber band in the freezer. It should stretch, but you put it in the freezer and take it out. That thing's not stretching. You put it in a warm environment, that thing will stretch all day long.
All right, so go back then here. Is it that Dr. A has 50 patients that ice responds better and Dr. B has 50 hot? Like, I mean, this is really... I never even thought we would go down this, but this took a rabbit hole in my brain. I'm just going to apologize right now.
Well, I'm going to apologize to you, Ken-Zee. I didn't even answer the question. I just went off my own tangent here.
No. I'll keep you on track with it because it's like this really is like completely detracting my own brain from everything I had for you. So.
Yeah, and so when we do the research, you know, it's one of those things where you do the research and then you just have to take the data that you're presented with and then you just analyze it and then you just present it with what it is. So sometimes, yeah, you could do a study where you're looking at, you know, 50 patients had an ankle sprain and 50% of them or 75% of them loved ice more than heat to recover from the pain. You know, and then there could be another injury like a low back pain and then now all of a sudden 75% of those people prefer heat over ice. Mm-hmm. And so again, it's like, well, which is better? Well, I guess again, what are the variables? What are you using it for? And it's just more of a preferential thing at that point.
Well, I talked to Ken-Zee a little bit about this earlier today. Do we have a problem in America where we tend to treat the symptoms and not the cause?
I love that question. I love it because that is exactly what we do. We do that all the time. Look at, so in our field, it's all about, it's more of a holistic approach. And so it's more about getting to what we call the source of the problem or the pain generator versus, you know, if you're having low back pain and you day to day and you say, well, I'm going to take some ibuprofen, you know, and at that point it's like you're just kind of covering up the pain symptoms and not really getting to the source of what's causing said pain. And we do that all the time in America. You know, we get people who just want to go in for surgery all the time. And there's nothing wrong with surgery. Surgery is a great thing. I had surgery last year. We have those techniques to make people better, but you know, people will go in and get surgery, think they're going to just walk out with like a new knee. And that's not always the case versus, you know, trying to treat something else beforehand if we can. And then if we need to do surgery or take medication, we have those options. But our first instinct in America is just go medication, surgery right off the bat.
Well, and I know you're not a chiropractor or anything, but I know a lot of people refuse to go to chiropractors because the first thing out of their mouth is, well, if I go, I'm going to have to keep going after the first time I go. Is there any, like I said, I know you're not a chiropractor, but is there any truth to that? That once you get adjusted, is it you get addicted to the feeling because you feel better, or is it they move some things and it moves back faster?
Yeah, that's another great question. We see that a lot too in our field. And when somebody gets adjusted, you know, there's certain chiropractors that will just do a lot of adjustments, and then they just kind of do a few adjustments and they leave and they say, yeah, come back. We'll see you once a month or once a week for number of 10 months, 12 months kind of thing. And there's a lot of the chiropractors, you know, that will go in and do an adjustment and then they follow up with some exercise. So the big thing about an adjustment or manipulation is you're creating more motion, right? So you get that adjustment because you're stiff. So you go in, you get that adjustment and you go through it and then everything feels good. Well, what you want to do is back that up because there's a lot of research that shows within 20 minutes of adjustment, it'll go right back to what it was.
Really? Mm-hmm. Well, I know there's a place here in Kansas City. They actually sell subscriptions to where you can get so many adjustments a month. It's actually pretty cheap too.
Ooh, not a subscription service I thought I was going to hear about today.
Right? It's pretty interesting, you know, and my thing is it can be great to go get those adjustments, especially if there's a spot where, you know, there is a movement restriction, but then there needs to be something to back it up with the muscles that surround that area to help either stabilize it or create that motion and keep that motion. That way you don't have to go back and do it all of the time. Now, every once in a while, sometimes people need a tune-up. Say you go travel and you sit in a car for 12 hours. Yeah, you're going to be stiff. You may need to do something or have some exercises in your back pocket or have somebody you can go see to kind of a massage therapist, a chiropractor, PT, somebody to get things to move again because the body's going to get naturally stiff. And so, yeah, sometimes you need like a little tune-up. But in my opinion...
Like how we tune up.
I should make sure my fingers are that way.
Well,
But it's one of those things where if you just kind of if you just keep going and going, again, like you asked, like you're not addressing the true problem at that point in time. And then you're not doing anything in your day-to-day routine or weekly routine to help facilitate, to improve upon what's going on.
speaking of doctors and best friends, how do chiropractors and physical therapists get along?
Oh, hit me with the big loaded questions.
I am
love
curious. I am curious. I know we've actually had this conversation before, and I know that you said both can go hand in hand. Both can have radical extremes. You know, that it's just like anything, anywhere people wise, there's going to be outskirts, there's going to be a majority, there's going to be, and so curiosity, you know, that answer from you has honestly, that's been like 4 years ago, probably. Like that was a bullshit conversation over a hockey game. You know what I mean?
Yeah. And again, with what you said, that there's going to be radicals on each extreme. For the most part, I would say probably it's kind of like maybe a mini rivalry between the two professions. I also look at it of the standpoint of I've got chiropractors that I've worked with very closely that are fantastic. And this is going to probably be the most PC answer you get today.
Oh,
but
fantastic.
just FYI.
Whee!
But I have chiropractors I work with that I think are fantastic. I've had chiropractors that I work with that I'm just kind of like, I don't know what we're doing here. Or I don't think this is what we're doing is actually affecting this patient and getting them better.
Says the guy that puts fingers up people's butts.
Now we're just making things up over here. I don't
tell
do
you,
that at all.
You
Just
gotta
because
you got to call Randy out for his fuckery.
And then, but then I've had PTs that I've worked with that I sit there and go, watch them treat their patient. I know what the patient needs to have done, or I know what they're there for. And you're just sitting there going, what are you doing? And I've got PTs, even for example, my boss today helped me with one of my patients, and you just have PTs that are just absolutely phenomenal, that are great. So I think for the most part, like in general speaking, PTs and chiros kind of, they don't butt heads, but there's kind of like that unspoken like rivalry-ish of like, oh yeah, you're a PT, oh yeah, you're a chiro. But then there are so many on both sides of the ball that respect each other, that work really well hand in hand together. And I think if you can kind of just look past some of the labeling of what you are and what you do, you're able to do a better job of what the overall goal is to work in collaboration and get the patient better.
So does that'll tie perfectly into something I've been wondering about with a lot of professionals, not just doctors, not just specifically this, but between chiropractors and PTs, how much of it is ego driven that you run into the clash?
I think a lot of it. I think majority of it.
The majority?
Yeah. Now there's different schools of thought, you know, and even within the PT world, there's different schools of thought. I know within the chiropractic world, there's different schools of thought, because I know there's chiropractics that go against each other, and there's PTs that go against each other. But a lot of it, again, even those scenarios, I think that's all ego driven. It's schools of thought, and you think your school of thought is better, and so you're just going to do that way and that way only, and that's the only way there is to do it.
What do you think does that to a doctor of any kind? And I'm not trying to throw PTs or chiropractors or anyone under the bus, but like, I understand you go to school for a long time, but you're in a classroom with like a bunch of people. What the fuck gives you the right versus them the right to have a school of thought, and then you end up in the same profession, same qualifications? How do you do it? Like, I don't understand the button heads at any level there. Like, what kills the open-mindedness of that?
I think it's ego, it's pride, it's you don't want to look dumb in front of the patient. Which again, I think comes down back to ego and pride. You know, anybody who is in some kind of professional setting, like you're out there, and if your ultimate goal is to just better yourself, like if your ultimate goal is to make yourself look good, I think that's where it's all going to stem from, because all of a sudden now it's like, oh, well, this person, you know, did this and it got better, but I did this and it didn't get better. Now all of a sudden your brand looks bad versus, well, what was the ultimate goal? Why is your goal to get that person better? Because again, like we talked about earlier, the field's changing. I mean, constantly changing all the time. We're learning new techniques, new research on what works best to get somebody better versus, you know, things we used to do that instead of just being like, oh, this person's gonna come in, they have back pain too, so I'm gonna give them these 5 exercises and that's all we're gonna do. Versus, okay, how are they presenting? What do they do? What are their daily activities like? What are their hobbies? Can we get them better that way? That is more specific to them. And I think if anybody, from profession to profession, if you get to the point where you do something and it makes the other person look bad, they're gonna get automatically. I think it's in human nature to become defensive, and then that's where it becomes more ego driven and pride driven, I think.
Well, Ken-Zee brought up the not the camaraderie, but the competition. What is the difference between physical therapy and chiropractors?
Ooh, can I go first?
Sure.
I'm an expert. Manipulations versus adjustments. Fucking A, Cotton.
Some of it's
First, was he right?
well, that is a terminology difference for sure. So in the physical therapy world, we don't use the term manipulation. We don't use the term adjustments. Let me step back. We don't use the term adjustments. Chiropractors use that term. We use the term of manipulation. Basically, it's a joint mobilization where we kind of move the joint, and at the end range, you go through what's called a cavitation, where you get that kind of what people know as that pop. Right. Sometimes you get it, sometimes you don't. Chiropractics will use the term adjustment.
Is that pop just air in there?
It's a buildup of nitrogen gas within the joint.
Okay.
So, and then once you get that pop, it's a release of that gas. And so the difference between chiropractics and PT, PT is going to be kind of a holistic holistic medicine of looking at how you move, and then backing that up with not all PTs do this, but some manual therapy to get things to move better, and then backing that up with exercises. Now there's a kind of been a shift in the chiropractic world where they're starting to do a lot more of that too. And I'm going to kind of mess this up, but in chiropractic, there's also a difference because chiropractics, if I'm correct, started actually in Iowa, and it's base of where it began. And there's some other kind of different things in chiropractics that not all new chiropractors practice, and it kind of gets a little bit more like the layman's terms of people kind of like, yeah, they did this one thing that was kind of like voodoo, and and it's not really voodoo if we're being quite honest, but there are some different things that they do that PTs won't do. Chiropractors are known for doing a lot of adjustments. They have a lot more different types of modalities, where like a table, I know all my patients who go to the chiropractor there's this table that they lay on that has like rollers that go back and forth that they'll hang on for a while, and then they'll do an adjustment, and then they'll get electrical stimulation. But that's a really good question that I can't quite answer, because I don't know kind of where the world of chiropractics is all the time. Just because with older chiropractors and younger chiropractors, they also they treat very differently too. But a lot of it too is just kind of how access to either one as well too. So, but physical therapy is also known for using a lot more just exercises and strengthening, stretching, mobility exercises, and kind of like returning to sport post-surgically, versus chiropractic is not as often as post-surgical. We get a lot more post-surgical than they do.
Well, you've brought up holistics quite a bit. Acupuncture, is it bullshit?
I want to say no. And I'm going to say no in the sense that we don't have enough research to go on it. And we've talked about this at work a lot too. And acupuncture, I mean, it's been around for thousands of years. Yeah. It's ancient Chinese or Eastern medicine. Yeah. It's been around for thousands of years. And I've had a lot of patients actually with spinal cord injuries who have done that, because in my opinion, it activates on the nervous system. And I can't argue against it because I've seen it work for people. There's just not enough. I don't think there's enough research to say, yeah, it's bullshit versus, oh, it's going to work every time. But it's also one of those things you can't just do one session and say, oh my gosh, that worked great. Or it didn't do anything. Well, yeah, you only did it one time. And if it's...
Well, the only reason I asked is like my mom's been going, and one of the first times she's like, oh, I feel great. I'm doing great. It's awesome. Then the very next day I can't walk. It's like, well, did it work or not? Did you overdo yourself because you felt great, or was it complete bullshit? So, I mean, I think you got to take that into consideration too. Does somebody feel really good and then go overdo it and then mess themselves up worse than they were?
And we have that conversation daily at work with patients. People will come in and we do some stuff, or they're recovering really well, And they go out and they come back after, like, say I see them on a Friday and they're leaving. They're like, yeah, been feeling pretty good all week. They come back the following Tuesday and they're like, man, I'm hurting. Like, I have not been in this much pain. And I go, well, what'd you do? And they're like, well,
Ran a marathon.
yeah. Or I went out and I mowed my lawn and then I did a bunch of weeding. So I was bent over for 10 hours.
2 weeks out of surgery.
Yeah. And you're just like, well, no wonder you went from 0 to 100 and, like, for no reason. Like, we told you, maybe just, you know, go for a walk. And you decided to do your entire 10-acre yard or garden or whatever it is, you know. And then so there's a lot to that. But there's with chiropractic, or not chiropractic, with acupuncture, it's one of those things where I don't think it's one of those things you can just assume like it works the first time, just because I think it's one of those things where you have to have multiple sessions of it for it to actually, as far as my understanding, to actually work. So
I want to dive down another route here for a second. Are you familiar with Wim Hof?
I am not.
It's the Iceman. Okay. He basically has a thing that the brain, the body can produce pretty much most chemicals, right? All the drugs, all the medicines, everything. Like, our brain can basically produce a lot of this kind of stuff, and he focuses on breathing. Holds a Guinness World Record. He's the only guy to summit Mount Everest in his swim trunks. A lot of things that he's done. Swears by breathing. Curiosity killing the cat. What level of breathing goes into physical therapy?
Actually, more than you think.
I'm hoping it's more than I thought.
Yeah,
I want you to tell
there's a lot of breathing. So it depends on what type of breathing we're talking about. With exercise and breathing, with weightlifting, there's the Valsalva maneuver where you actually hold your breath because it creates more internal pressure, which can actually help you increase more force production when you're lifting weight. So you see a lot of Olympic athletes, a lot of power lifters use that maneuver all the time. The unfortunate thing,
And that's why a lot of them pass out too when they do
that's
it.
exactly why, because their blood pressure will shoot way up or drop way low. Usually shoots way up because the internal pressure increases. And so, yeah, they'll do a maneuver and then they'll pass out later. Unfortunately, in the civilian world, so that's probably not the right word, but in our world, when people go to the gym, they go to the rec center and they're doing that. And if they already have cardiac issues and they're trying to lift heavy weights to get in shape, and they do that, they can have an aneurysm because the blood pressure increases so high,
and so fast, and
that they're not used to it, and their body's not used to it because there's already cardiac issues or arterial issues creating an aneurysm. But that's kind of more on the scary side of things. But in our world too, we'll get a lot of people with chronic pain who come in and their nervous system is just skyrocketed high. And what we know about anxiety and stress is that it can actually create physical pain. And so working on breathing techniques, there's all kinds. The most common type that everybody kind of has heard of the most often is box breathing. So it's a technique where you breathe in for 4 seconds, hold your breath for 4, exhale for 4, hold for 4, inhale for 4, and you just kind of go in a box of that nature. And so with that, there's a lot. It can actually help decrease the sympathetic nervous system, slow down your heart rate. A lot of athletes will do that. Shoot by athletes when they're skiing and shooting, they get to the point where they have to shoot after they've been skiing. Their heart rate's elevated. You'll see them start taking some deep, slow breaths. What that will actually do is calm down their nervous system and start slowing down their heart rate.
All right, man. I'm gonna have to show you the Wim Hof stuff that I've got later. We're gonna have to hang out and do that.
Especially if he's going up Mount Everest in swim trunks. My God.
Oh, he teaches it. He actually, like, you can pay and go out and stay with him, and as the passing of the course, you climb a mountain. It's not Everest. You climb a mountain. I want to say it's like 21,000 feet, if I remember right from what I remember. But you climb a mountain in your bathing suit with him and the other class members. And you have to realize that you're also gonna, he cuts a hole in the ice, out in the river, and goes and swims to another hole in the ice every morning. He doesn't cold plunge, he cold fucking does it. You know what I mean? He cold sends it.
Yeah.
He's known as the Iceman. He's also got, I think, the Guinness World Record for time in an ice bath or something wild. The dude is all he is.
I think he's got the record for holding his breath underwater.
I think it's underwater, and I think he's got time in a like freezing temperature water. So,
that too. I think. Yeah, you're right.
Honestly, he's got a mind fuck of awards, and all of them seem like magic. But he says none of it's magic. I just breathe.
He's able to just slow his heart rate.
He just
breathing exercises.
Yeah, but yeah, and like he's. Well, I'll show you.
Yeah, you'll have to show me that. That sounds interesting, especially with the climbing the mountain part too. Because I mean, you climb, right? Your heart rate just elevates like crazy.
Again, there's a lot of pictures and documentation of him doing it.
Oh, I believe it.
Then there's me who can just slow my heart rate by breathing out with a cardiac arrhythmia or whatever it is.
Proud of you?
I don't know. Supposedly it's not going to kill me.
No, it won't. That one won't.
Everything else I do will.
I'm not a cardiologist, but at least that won't kill you.
So
that's a sinus arrhythmia. Sorry, sinus arrhythmia.
That's a very different than a cardiac. I think
it's a cardiac related.
Yeah, but
it's a sinus. It's a sinus arrhythmia.
It's part of the sinus is part of a heart.
Shut up. I mean, what do you know?
Like he's a doctor or something.
You asked.
What do you know? All right. Speaking of what do you know, what do you kind of wish you knew at this like going back, looking at it all from this perspective, kind of diving back in, but maybe not specific to your education or educational path or et cetera, but like, what do you wish you know that you could have told yourself when you started this path and you realized, I'm going to go for a PT?
Yeah. I wish I've known to, going back, if I wanted to be a PT, which I did, going back, tell myself, hey, you need to start talking to schools earlier than what you did. Because physical therapy school is super competitive. So it's actually, the last time I checked, it was the second most competitive medical type program to get into, only after veterinarian school in the country. So it's a super competitive program. I also wish I would have known to say, hey, if you're going to do this, great. It's what you want to do. Start looking again at state schools or in state schools versus private institutions or out of state schools, unless you're going to move to that state for a year and then do it. That's probably one of the biggest thing. And then looking for, I think there's some schools that have scholarship programs, looking for that as well too. And then just going back and telling my old self, hey, look, here's the setting that you're going to want to work in. Here's probably what you're realistically looking at making, because in our setting, what we do is actually one of the lower paid settings in our field, in the outpatient world.
What about as a PT though? What would you go back today and tell yourself day after you graduated and you're getting a job?
Don't sell yourself short. You get out of school, and I think this goes for most professions, especially medical. You get out of school, you just have your basic training. You don't have a ton of experience, right? You just graduated, and the only experience you have is working in your clinical rotations that you did. Don't sell yourself short on, where you don't have to take the first job that you get offered. If you have to move somewhere, like move back to your parents, if you have to move with a friend for a little bit and then do something, but don't sell yourself short. And then apply to every job, interview at every job. And I had a great experience in my first job, but it's one of those things where, I think a lot of people will take that very first job they get offered, and then, you get lowballed on what even though you're a new grad, what you should be making versus what you could make.
You get excited and then short-sighted and then realize, oh shit, there's a lot more out there.
I was just telling you where someone had a few too many drinks and said they were able to, auction professionals down instead of the other way around, because it is getting to be a weird time to be there, if you will, in a weird competitive state.
Yeah, and I would also say too,
phrase that.
I would also say to myself too, keep learning, keep doing what you're doing, but again, don't be afraid to take risks coming out of school of just continue to learn and, ask questions, and don't be afraid to move. I know a lot of people will get that first job and they're like, I want to be here. Well, I mean, go out and experience some things too. Go work somewhere else sometimes, because the more kind of different places you can work and see, you get exposed to other fields and things, and you never know what you're going to learn.
Well, I know I'm guilty of it too, but statistics are showing that you lose anywhere between 20 to 50% if you don't switch jobs every 3 to 5 years. The good thing is that there's physical therapy everywhere. So definitely while you're still young, start looking and don't get settled in and think this is where I'm going to be the rest of my life.
Yeah, and that's actually a really interesting point because that's kind of been the freeing idea when I left Fort Worth was, I know I was coming back to Kansas City where I grew up, but that's kind of the cool. I will say one of the kind of cooler things about our degree is there's travel opportunities. Sometimes they pay really well, sometimes they don't. But the other kind of cool things too is I can work pretty much anywhere. And that includes other countries too. So
You just kind of need people to be there, right?
you just need to be at an area that has people. And there's a bunch of rural settings too that people will go to. And I've got friends that work in super rural areas and that people will drive to them. And it's great for them. They love it.
There are a lot of people.
There's a lot of people everywhere.
That's what I'm saying.
Speaking of which, did you see the recent article that came out that they think that they've vastly underrated the world population?
I did. I think we're up to, everybody's been saying we're around 130. I think we're actually up to like 150 to 160. 330-ish. We're up to 300.
I thought the US was at like 360.
Yeah, that's what I was going to say. We're now within the last 2 years up to 350, 360.
That's not like shocking to me, I guess. I thought that's what I've been seeing for a while.
But yeah, but the world as a whole is...
Instead of being like 7 billion people, they're thinking like we're like...
Well, I think we're, 8 something right now?
Yeah, they think we're
8.6.
Yeah, they think there might be even higher.
9, approaching 10. Well, and that's the thing, too, is that in the article I did read, and it's probably the same article you read, you got to remember, there isn't census in most places. Like we do in the United States, but how many people actually sign up? It's a guess. So go to India.
Homes?
What's that?
How many rural homes don't fill?
Oh, yeah.
And that's where they had to actually, that was their point, was they think they vastly underestimated the rural settings. They vastly underestimated how many people are actually living in rural areas.
Ooh.
I could see that.
I definitely think that's an interesting one. Send me a link.
I'll have to, yeah. I didn't mean to kind of diverge, but as soon as you said that, I was like, oh man, that just reminded me of an article I read recently.
I think Randy and I love getting questions, actually. You got another question for us real quick?
Not right now,
okay.
But if I come up with one, I'll definitely hit you guys with it. So.
Speaking of overpopulated, do you see they found a $13 trillion gold vein?
I did see that. And again,
I wonder how that's going to shake up the market.
With new tech and new drilling and everything else, plus all the other stuff that we know about people in the past faking it, could get weird and could get interesting.
So, with physical therapy, is physical therapy mostly covered by insurance?
Oh, so glad you asked.
Because I know if most time you go to a chiropractor, it's out of pocket cash.
So, it depends on the insurance company, and this is the struggle that we have every single day at work. Majority of insurance companies cover physical therapy in some form or fashion. Whether it be, some insurance companies are great and they'll approve the plan of care, which what we write up and we send to the doctor's office and they sign off and the insurance company says yes. Some insurance companies give you 20 to 60 visits per calendar year. Mm-hmm. For example, when I have a patient with a total knee replacement, usually I'm seeing them for like 24 to 36 visits. Probably about a minimum, somewhere in that ballpark.
It's quite a few days a week post-surgery, isn't it?
Yeah.
And then it spreads out.
Yeah, and sometimes they'll come in 3 days a week. I usually see people 2 days a week, 2 or 3 days a week. And then it's usually for like a total knee, it's usually about 3 to 4 months. 4 months being on the longer side, 3 months being kind of average. Mm-hmm. So it's about 12 weeks. So 2 times a week for 12 weeks, you're looking at 24 visits. So, and somebody may have an insurance company that only gives them 20 visits for a calendar year. So say they have a knee replacement in January and they use up all their visits. If something else happens, they're not going to have any technically approved visits when they're paying out of pocket. So they're not only paying for their insurance, but then they're paying out of pocket after that because their insurance company won't approve it. We've also ran into the situation where, people will have, the insurance company wants them to go to therapy for 6 visits before surgery. Mm-hmm. So they do that. Then they have surgery, then they come back, and they only have 14 visits. that's approved, and then now they're paying out of pocket. Other insurance companies require authorization, so they'll have surgery or just they're having pain, even though they were authorized for them to go to their doctor. They go to their doctor, then they come to us. I can do the evaluation, and now I can't see them again until I finish my evaluation. Send it to the insurance company. They read through it and say, yes, you can go to PT. Jeez. And then they give us an allotted number of visits. Again, it just depends on what insurance you buy. And so that's where we have to try to educate our patients. And we try to the best we can, especially our older population, when they're getting ready to get Medicare or they're going to adjust their supplemental program that they have. We try to say, hey, here, if you're wanting one that covers physical therapy, here's some ones to look at, because not everything is, just because you have insurance doesn't mean it's going to cover everything you want. And that's where I think most people don't understand how insurance actually works.
Okay. Definitely that last point. 1,000%. Most people don't understand how it works. Diving specifically, though, what are your thoughts as a doctor on insurance as a whole?
The idea of insurance is great. It's what it's supposed to do. It's supposed to cover you to help keep you healthy, and cover costs that you're already paying them to cover the cost of what medical procedures cost, especially in the United States. In reality, insurance is awful. I can't stand insurance companies. I can't stand how they function and how they process most of the time, because it really limits me on what I can do. And sometimes they tell me what I can and can't do in my profession and what I've been trained to do. And that's not just me. It's other professions as well too. Dentists, MDs, DOs, chiropractors as well too, if they accept insurance. Well, some of them do, depends. And then you get into the realm of workers' comp insurance, which is a whole nother ballgame after that too. But as a whole, not a fan of how the idea of insurance companies, great. It should work way better, and it used to work way better. And now I can't stand them. We fight them every day on a daily basis.
It's like what? May? And I'm already out of pocket for any dental procedure. Just had to drop $1,300 for a cavity and a deep clean.
Mm-hmm.
So go with me here for a second. Should insurance companies be able to have commercials on TV with celebrities?
No, I definitely do not agree with that.
Should they be able to name stadiums?
Going with SoFi, I'm guessing. Oh no, SoFi's a student loan, or is the loan processing? Probably not.
What would you do with your knowledge in the medical world that you work in, etc.? What would you do as a quick fix to at least start moving the needle in the right direction?
From what my understanding of how things used to work with insurance, how they work currently, I love the idea of kind of going back to the way insurance used to work, as far as I know how it used to work from talking with other coworkers who, in our billing office at some other jobs that I've had, was insurance used to work with, you would go to your doctor, you would go to your dentist, and you would pay something out of pocket, and then you would submit the claim. They would give you a receipt, and you would submit that to insurance, and they would reimburse you, right? So that way the practitioner was more in control. They determined what was necessary based on their schooling, based on the patient and what they saw, versus what it is now is you go to the doctor, you may pay a copay, and then you get, now all of a sudden, so recently I went to the doctor. Luckily I didn't even have a copay, which is nice, but now all of a sudden I go in, do just a yearly checkup, run some labs, and now all of a sudden I get a bill in the mail for $340 on just a normal yearly checkup and running labs, where it's one of those things of like, you accept my insurance, why doesn't my insurance cover all of that, which should be a standard just yearly thing.
You would think it would be better for an insurance company to keep you healthy.
Exactly. And unfortunately, what we talked about, I don't know if it was before we started or when at the very beginning, I can't remember, but what we talked about with, are we just covering up symptoms? Are we just doing a Band-Aid? Oh, we talked about ibuprofen. Are we just covering up with Band-Aids, or are we actually trying to make people more healthy and more preventative care? And that's where I think what we lack in this country is we lack preventative care, versus we're in the mindset of, oh, now we're hurting, I'm going to go in, which is fine. That happens to everybody. We have things pop up, but it's less preventative care and more just responding to the symptoms.
Yeah, it's like, oh, you need to lose weight. Well, we'll give you Ozempic if you have type 1 diabetes, which you will have because you're overweight and obese if you don't have a heart attack first. But you have to have that first instead of, hey, let's cut out the $1 million heart surgery and everything else. Let's get you down to weight and being healthy. It's no, we're going to wait and do that $1 million surgery. And
well, dude, it's tough to find obese people in America.
oh, so tough. Yeah. I actually read a statistic, and sorry, just reading a statistic. 2/3 of American women are now obese.
Oh, fun. I think 2/3 of American men probably are too.
It's like 70 or 60 some percent of women, and it's like 50% of men.
I would say that 50% of men actually, I feel like it's probably right, but I feel like that's low just because I feel just based on our food consumption. Diet.
Well, the crazy numbers too, that just what they consider obese. I'm not a doctor or anything, but it seems like those numbers are kind of skewed because they don't take into consideration muscle mass and all the other stuff that goes with it. But that's neither here nor there.
Wait, stats by doctors could be skewed? How would that possibly be a thing?
Never.
Actually, I was talking to a patient about that exact thing last week. My biggest thing is you go to the doctor and they say you get your BMI and you look at, say an athlete goes in, say you take
LeBron James.
If we take LeBron James, okay, great example.
6'8", probably close to 300 pounds.
Yeah, he's going to go in and he's for sure going to be he's going to be considered obese on the BMI scale.
Probably has 3% body fat.
Yeah, and because it doesn't take in the better individual scale. It's fine on the national level because the large numbers are so large.
Correct.
On an individual basis, when you go to the doctor, it's terrible. It's one of the worst things. Your doctor comes in and you come in and they say, "Oh yeah, you're overweight," and it's like. If it's somebody who is an athlete and they come in, they're like, what do you mean? I play collegiate sports. I play professional sports. I run like all day and I have 6% body fat where that's super low for women. And it's really actually low for men. Mm-hmm. You're looking at that's not right.
That's top tier athleticism right there.
Exactly.
So I had this idea the other day and it's one that I think I've stuck with. The questionnaire going to a doctor is kind of bullshit to me because I think a doctor should have to come in, talk to me, measure my heart, and do my pulse, do my blood pressure, etc. Measure like height, weight, all that shit, and then we can discuss what might have been on the questionnaire rather than all of these answers that they're hoping for. Honestly, so that they can just go, well, this fucking guy's a little overweight and drinks a little too much. I ain't got it.
They don't even ask you that stuff anymore. You go in and basically they ask you if somebody beats you at home.
Yeah, but that's what I'm saying is to go to the doctor nowadays, the terms of service, essentially. The agreement to go to the doctor is that you'll fill out the questionnaire and be a good boy. And I've always laughed thinking if you were a good doctor, I should be able to sit on the fucking bed until you're ready. And then you come in, talk to me, do your normal stuff. And then we can figure out, is there anything I should really be worried about right now?
Yeah, and I think that comes down to I think it comes down to individual practitioners because, again, not all doctors, not all PTs, not all chiropractors, not all dentists, they're not all the same. They have the same schooling for their profession, but they all treat and act differently. The other thing, too, is, again, it kind of comes back to my point of earlier with insurance, it's all dictated by insurance. The reason you go to your doctor and you go in, you sit there and you wait 45 minutes in the room for them to come in to talk with you for 5 minutes is because their schedule is so packed and they can only spend X amount of time with you because they have to have that many people because what insurance companies are reimbursing medical professionals is those insurance companies, they literally hire people to look at all those claims and try to deny where they can. Yeah. They're trying to, like you said, should they be able to name a stadium? Should they be able to have movie stars on their commercials? It's one of those things where the most medical practitioners, their hands are so tied, they have to see so many patients in a day to one, break even, and then two, to make any kind of profit for their liability insurance, their rental of their space or their building, their staff themselves. It all adds up so fast that you have to see that many people because insurance companies are reimbursing sometimes not even 30% of what medical professionals charge.
Well, one crazy thing that you brought up earlier is like knee surgery and everything and how the practice is changing. One thing that I always thought was crazy is like we used to have knee surgery. They would say, here's some ice, go lay down, rest, relax. Now you get out of surgery, they're wheeling you to the room. Before you hit the room, they're waking you up with smelling salt, smacking you across the face and saying, we're going for a walk, fucker, let's go. It is crazy how they cut you open and they're like, okay, walk on it, let's go.
Yeah, and it depends on what kind of surgery you're getting too. So total knee replacement, you are 100% on point. Yeah, what the newer research shows is it used to be. So my mom was an ortho nurse in Minnesota for a little bit, and when they'd have total knee replacement done, people would be laying in the bed for
months.
Yeah, 2 or 3 weeks at minimum, if not longer. What we know now is those patients actually end up being worse. And so what we see with total knee replacements especially is the quicker, and hip replacements too, the quicker you can get somebody up walking, the better the outcome.
I mean, my dad just had it done. I know you ended up on the phone with my mom helping out because my dad he can be a real bitch at some points. I love him to death, but he just, it hurts. Man, get over it, man. You had your knee just hammered on. Like, come on. And it's going to hurt.
Yeah, and what's crazy is, like, to that extent, and you talk about waking somebody up with smelling salt, slapping them across the face, which I think would be the most hilarious skit ever, by the way, for some comedian show, is, having somebody do that, but then, getting them up, and most people don't realize how brutal that surgery specifically is.
Oh, I've seen some videos where they've got like sledgehammers and
the knee replacement. They're hammering.
Some titanium rods. They're just pounding on it.
That surgery is brutal, and it's so funny when patients come in and they're like, "My knee really hurts," and I'm like, "Yeah, no shit. Did you watch how they did it?" And they go, "No," and I go, "Well, do you want to know?" And they're like, No.
I think if you showed them beforehand, I would say 50% of people would say, I'm living with the pain.
Dude, screw it. I genuinely wish I had one of those videos that they have for you guys in school or some shit to just like, see, Dad, this is why it hurts so bad.
Well, and what I've noticed that some people are doing, some doctors are doing now, there's a couple surgeons down over in Overland Park right now that what they're doing is they actually have a class they require you to take before you have surgery.
Damn.
Which I think is genius because they go over how the technique's done, which they don't show the video, which some people are squeamish, I get, but I think they should show the video. You can see
I've seen a couple of them, and they look. I mean, I've seen people holding it, and doctors full on like a sledgehammer hitting that thing.
It's brutal, absolutely brutal.
Oh,
but then they go over expectations too, because again,
that part's important.
Yeah, it's huge because I worked in Texas. I had this gentleman who had a total knee replacement, and he came in and he was like, "I just don't understand why my knee hurts so bad." And when he said that, and he goes, "I didn't think I was gonna have to have this much therapy afterwards." And I looked at him and I said, "Did you think you were gonna like be a car and like walk in and get a new knee and walk out?" And he goes, dead serious, looks me dead in the eye, goes, "Yeah." I was like, "You are not a machine. You're a human being. Like, it has to heal."
Good news, we found someone dumb.
Oh, you talking about my knee?
No, I'm talking about the guy who just thought he was going to get a new one and walk.
Oh yeah, yeah. That was wild to me. I just didn't think of like.
I was slapping your knee to remind you there are dumb people everywhere.
Oh well, I didn't know if you were slapping my knee because that's the knee that I had surgery on.
No, we're coming back to your dumb here in a bit. That's for sure. That's for sure. I wanted to come back though. So insurance is only reimbursing 30%. Some obviously that. Laughably. What about this, like, okay, and I understand it's a profession. I understand they go to school for a long time, and then they have a specialty, and I get it. But an anesthesiologist just knocks the fuck out of you. And I feel like that's a pretty easy profession. And their billing rates, holy shit.
I would argue that their profession is not easy, only because I've seen it firsthand with one of my really good friends. His wife's a nurse anesthetist, and seeing what schooling she went through. And all of the different types of anesthetics out there, all of the types of, the things they have to know and keep track of while somebody's in surgery it's a lot. And you also have to look at the person's medical background, what kind of medication that they're taking, if they've been, so the other thing too is like, if you have, a lot of times they'll cancel surgery. I've had this happen to patients. They'll cancel surgeries if you've been any kind of cold or sick within like 48 hours of your surgery, and they'll ask you that. And the reason being is because it affects the numbers, because the numbers that they have to control are so fine tuned that you could die.
Well, here's a crazy fact that I've heard. I've heard it multiple times, so I'm assuming it's true. Redheads. anesthesia affects them different. They have to use more on redheads because something with the pigment in their body reacts different.
Not the lack of soul.
I mean, that could be. I mean, I forgot that gingers have no souls. So a little harder to knock them out.
Yeah, and then you have to look at the genetic differences in people of how much anesthetic do you have to use. Some people are allergic to certain types of anesthetic, and then any kind of, like, again, drug interactions and things you may have to be aware of. And then again, because, I mean, the risk of death is so high. Well, I guess not the risk, but the standard deviation of error or something. I think I'm trying to think, but basically the room for error that they have is so little that their liability risk is so
Like their
high.
margin of error.
Yeah, thank you. That's exactly what I'm looking for. It's been a long day.
Biggest thing that scares me though is I haven't had a lot of surgeries, but I had the pleasure of watching the movie. I believe it's called Awake. Maybe. I think Kip Purdue. Basically, rich guy, girlfriend, and doctor go in together, and the doctor's plan is he needs heart surgery. So the doctor's plan is to give him just enough anesthesia where he's knocked out but can feel everything and put his body into shock from the pain. And the movie is him compartmentalizing everything in his brain while he's awake and feeling it all, and somehow doesn't go into shock.
I got a question for you. Better or worse than the Human Centipede?
I've not seen that one. I refuse to watch that.
No, not the movie. The concept.
Oh, the concept?
Would you rather be in surgery, feeling everything, but not in shock, and cataloging it in your brain, or sewed to someone's butthole?
I
need an answer, Randy. This is not I don't know. This is I need an answer.
After seeing what they do to somebody's knee in surgery, I'm taking sewn to somebody's butthole. Because
That's fucking awesome.
Because holy shit, what they do to that knee is.
Here's the good news.
It's like John Henry straight busting some railroad spikes.
And he's not wrong. And sometimes that sledgehammer is from your Ace Hardware right down the street too. It is not a medical hammer. It's a hammer from a hardware store. Seen those in the OR before. You look at it and go, you walk into OR and you see the surgeon, you look at it and you go, I think my dad has 3 of those on his garage bench.
Still got the price tag from Ace on it.
God bless. I mean, okay, we're just going to go back to you for a second here, Randy. We're going to make sure that you know. You're the first person to volunteer that answer as your choice here. So we're going to make you first, so you at least get food, and then you just deliver.
That works.
Brett, I've got another one for you.
Hit me.
All right. What do you think with regard to medical professionals and phrasing. What I consider you doing is necessary or like for the betterment of a human body. Whereas if you go to Miami, there are a lot of people that are doing BBLs, and
Elective.
I don't think those elective things, are right. Are not are right, but are. I'm curious to hear your thoughts as a medical professional about necessary versus elective.
Yes, and that's where terminology gets so gray.
Oh, I know insurance companies love to determine what's necessary for elective. And just so you have context, we should have actually texted Joe, one of our previous podcast guests here. He was in a head-on collision and a drunk driver hit him, and I mean the dude went through a lot of reconstruction, a lot of PT, and when we had
basically neck up and boobs down, everything crushed.
Yeah.
Oh my gosh.
Yeah. We had him, and he had just had his eye mesh removed from his eye socket, you know,
because it was poking out through the skin.
It was rubbing his hard hat. It was bothering because his mesh, his steel mesh in his head was rubbing his hard hat. So like,
terrible.
I genuinely have this thing where I'm really struggling with elective right now. Elective surgeries on like nonsensical shit like your ass for aesthetics.
Well, you have the weird stuff too where people are now identifying as disabled and are trying to get insurance to let them amputate body parts and stuff, and then they go take it on themselves because insurance says no, you're mentally ill, you do not need your arm amputated, you're perfectly fine. Well, I feel disabled. Well, just because you feel that way doesn't mean we're going to cut your arm off.
All right, you found a weird one on the back of TMZ somewhere.
I mean, it's happening more and more. It's crazy.
All right, we're diving back into elective versus necessary.
So based on terminology, elective versus necessary. And necessary to me is going to be, do you need that surgery, one, to live? And do you need it to function? Do
Can
you
I
need
interrupt
that?
you?
Sure.
I didn't mean surgery specific. I guess I mean anything elective. Or I guess maybe I just interrupted you for no reason, because maybe it is mostly surgery. That's elective.
Mostly surgery, and I would say more it's like quality of life is probably where you're getting at.
Yeah,
Okay.
absolutely.
Okay.
Can you function? It's going to be one. I think it's going to be basically life or death. Obviously,
Well,
it's
yeah,
going to be
of course.
necessary versus elective. Obviously, the other one's going to be exactly like you hit on. It's going to be quality of life and like functioning as a normal person.
You can live without getting the surgery, but can you function at every everyday normal level as everybody else?
Yeah, and one thing I'll kind of hit on with that that's becoming very interesting is there is ACL injuries in the knee. So it's very interesting, and I know this kind of from firsthand experience with the recent knee surgery that I had last year. So with that being said, and then we'll kind of hit on, like you were talking about, like people down in Miami or Brazil or wherever.
Again, I just know that Miami has a BBL scene.
That's 100%. And so the thing with necessary versus elective. So technically, an ACL surgery is more of an elective procedure.
Are you serious?
So that's the thing, and I think a lot of it has to come to do with media and how we perceive ACL injuries.
Oh, fuck.
So
The MCL's the main one, right?
So there's 4 major ligaments in the knee. There's the MCL, the PCL, the ACL, and the LCL.
And then you got the meniscus, which is all the cartilage.
And then you have the patellar tendon on the outside.
You guys ever think about dropping the CL and just going with the A, the L, the P, and the...
Well, you can. I mean, if you're talking about the knee ligaments, yeah, because it's just anterior cruciate ligament, posterior cruciate ligament, the medial collateral ligament, and the lateral collateral ligament. And so basically,
We can all make words up.
Yeah.
yeah, and it's Ken-Zee, it's just your basic Latin is all it is.
I tell you what.
But
That's a dead language. Nobody uses it anymore anyways.
Hey, Pitbull means baby protector too.
there you go. And so, but with that, we see ACL injuries in sports all the time. Soccer, football, basketball.
Yeah.
And the way the media's made it out to be is it's this, I mean, don't get me wrong, it's not a great injury. And yes, do people struggle with it? Absolutely. And it's a big deal because what happens is that ligament tears, and then all of a sudden now the knee's a little bit less stable.
You get that wobble in there,
Exactly.
side to side, right?
Yes. Usually it's going to be more, usually the side to side is going to be more limitations with kind of some, what we call dynamic control, using some hip muscles, ankle muscles, which allows the knee to kind of cave in.
Gotcha.
So that's like running backs losing the running part of that word.
Or the being able to cut.
That's the running part of that word.
Exactly. Yeah.
Gotcha.
Yeah, you're right. Jerk. But what the thing is too, though, is there's a lot of there's a physiotherapist, just terminology. He's a physical therapist, but they call him physios in Australia. His name is Mick Hughes, and he has done a lot of research in the past with professional soccer players who have torn their ACL, never had surgery, and still play very high level professionally.
Whoa.
So the other thing too is, yes, it's a knee stabilizer, but there are plenty of people, and I know this because I've worked with a collegiate athlete who didn't have an ACL, and I had an intern who had a lax ACL, and they're able to function fully and normal and still play pretty high level sports. So you don't necessarily, and the initial injury, there's a lot of swelling, but once you get everything calmed down, if it's completely torn, there's not any pain. And it's because there's no nerve endings to tell your brain, hey, this fucking hurts.
I've heard that actually, is that the pop and then there's actually no pain and that they have to go get it.
Correct.
That's why, like, you don't know if you tore your ACL other than the person felt the pop.
Correct. And that happens a lot. And so you can technically, it comes down to now, is it necessary or is it elective?
Fuck.
Because if you can actually function and still run, I had a for example, I had a rugby player. She tore her ACL. Everything calmed down. She kind of got back to normal, and she had the surgery. She had to wait 3 months before her surgery. But the week before, or the week of her surgery, she was leg pressing like 350 pounds. You can still completely give it time to calm down and strengthen everything around it. You can still function. Now, there's other injuries, like, unfortunately, I'm going to go with my personal story, where I ruptured my patellar tendon. So my patellar tendon is the tendon on your kneecap that sits just below your knee. A lot of basketball players get patellar tendonitis. That's where I developed mine initially. Volleyball players will get it too because they jump. My patellar tendon or Achilles tendon, that one happens a lot. Mine ruptured off my kneecap. But what people don't realize is I had people say, well, at least it wasn't your ACL. I sat there and realized and told them, you realize that when my patellar tendon came off my kneecap went from where it is, because that's the only thing that holds it in place, to the middle of my thigh. And you cannot actively straighten your knee without it. My knee was bent, and I tried to straighten it, and I looked at it, and I tried, and I couldn't. I'm laying on the ground. I can see my femur through my skin, and I can't straighten my knee.
You've got to see the video. You may have seen it. A rugby player, huge man. That happens to him. He grabs his kneecap and pushes it back into place, and then takes off running again.
Well, and so he probably had
a dislocation, maybe, or
so Patrick Mahomes had a patellar dislocation, and so nothing was torn. The thing is that just goes out.
Yeah.
All you have to do is get it back, and it's going to hurt. It's not going to feel great, but then what you need to do is stabilize it. And so once you get everything around it to stabilize, you're doing great. But if that thing ruptures, or Achilles tendon on your heel, if that ruptures, you can't act. So once you can lift your leg up, but to try to push it back down, to try to push off, to walk off your toes.
Well, that was like Jason Tatum just tore his Achilles, and he was in surgery within 12 hours.
And it's because it's more of a necessary surgery, because you can't function normally without either one of those tendons.
Well, yeah, I mean,
the joint can't work.
If you got 4 and you're telling me that one of them can tear and you're fine, insurance company got to be looking at that like 75% C's get degrees, bitch.
Yeah, exactly. And so that's why they're classifying an injury like the ACL as an elective surgery versus necessary, because there's a lot of research out there that shows you can function normally. Now, if you're going to be a high level athlete, like going to college, you have dreams of making the pros, or like even if you're a weekend warrior and want to have a more stable knee, yeah, you're going to want it fixed, because you're out of the 4 ligaments that stabilize your knee, you've lost 1. You're down 25%.
Yeah.
And it's in the motion that it controls. It's an important motion. So, a lot of people will have a PCL, a tear, and sometimes they don't get that one ever fixed, because that one doesn't really, it stabilizes the knee, but it's less common to have that.
What's the one they usually replace with cadavers?
That's going to usually be the ACL.
Is
so they'll do ACL. There's different techniques, which is again what we talked about earlier with the change in research. There's cadaver, there's patellar tendon, there's hamstring tendon, there's quad tendon, and that can be from your own body, that can be from a cadaver body. So yeah, pretty interesting stuff.
Well, since we're talking athletics and stuff, do you think that they're jumping a little quick to the Tommy John surgeries now? Because it seems like everybody, it's just, there's some inflammation, we're gonna go in there and start cutting on it.
Yeah, and I feel like with that too, it's more or less, especially with the younger population, because of the way youth athletics have become, how popular they've become, and how intense they've become. Kids are specializing in one sport so much faster than they used to.
True.
And that's creating more of these problems at a younger age that we're seeing. And so, yeah, I feel like they're kind of getting more into like, let's do Tommy John surgery because you see the inflammation, versus like, well, why don't you just take a break? Why don't you rest? Why don't you?
Well, they've got a $50 million a year wrapped up in that arm, so they need it back and working.
And if you're at the professional level, and unfortunately probably now at the collegiate level with NIL the way it is too, yeah, I mean they're gonna push for it, because they're gonna want you to come back. And there's instances where they talk about, and I have some coworkers that are that actually played collegiate baseball, so he'd know more about this than I do. But you've got some people that come back. Really, they come back and they're never really the same, but sometimes they come back, and because of that ligament now and how they replace it, sometimes they throw even harder. I
was going to say, I know about 2 years after, a lot of those players now, they're coming back throwing 5 miles per hour harder than they ever did their whole life.
And I think that's more common now because the technique is so much better, and then the recovery, as long as they take the time to recover and get stronger.
I was going to say, they've got they've got for the first time in 20 years time to rest their body, and then they've got the specialized training that they're getting to work that muscle specifically. So, I mean, I'm sure they've got it down to a science to where might be just like that little tweak, make it a little bit tighter to add that.
Yeah, and the surgical techniques are better too, because we'll even have labrum repairs in the shoulder, and they'll come in, and it takes, for the common person, sometimes it takes a year, like a full year, to get that shoulder to loosen up, because the surgeons have gone out and just tightened it up so it doesn't happen again. And like all patients go back, and they'll come back and say, yeah, my surgeon said he really made it really tight. And you're just like, which I need to go back and look and see how they do that nowadays, because I'm like, how do they make that capsule tighter? Like, I mean, what is that technique? But yeah, they're making things tighter, and so at that same time, you can develop more force and you can throw harder. It's wild. It's like the $1 Million Man.
It's almost like if you were the right pitcher and you were to get it the right Tommy John surgery, you could almost come back harder.
Yeah, it's like, did you ever watch the movie rookie of the year.
Yeah.
Oh yeah, it's like you break your arm, you get out of that cast, and all of a sudden you're throwing 95 miles an hour for the Cubs as an 11-year-old, 12-year-old.
Yeah, I'm sure that's common.
Oh yeah,
So, sports and injuries, fun one here. Does NIL and these athletes going and getting, private physical therapists on retainer, so to speak, and stuff like that, is athleticism due to sports gambling and due to NIL and all of this other, all the bullshit that goes into sports, the background noise of sports, you know what I mean? Does that create more demand for a physical therapist?
I think the contracts on top of that also, because you got somebody that's hurt sitting on a, they're getting paid $50 million a year now. In some instances.
Yeah, this is an interesting topic. I've talked about this with coworkers and patients before because I've seen enough from people that I've had classes with in the past, postgraduate classes. You would be amazed how little money teams spend to get top tier professionals sometimes. For example, I know there is a soccer team in the MLS that their team physicians are volunteers. They don't pay their team physicians. A lot of times if you see openings for certain jobs as a PT, I know, my buddies and I we look randomly at job openings, and we found one for, I think it was I had a buddy send me one for the Spurs, and I know there was one for the Lakers. And you look at the overall salary, you make pretty decent money, but then you start adding up how much you're actually working, and it doesn't really add up.
Well, the local brewery here, there's a man who was a doctor for the Super Bowl, I believe, winning team.
Oh, are you talking about the one of our older fellows who? Yeah, he was the Rams.
Rams, and he is now he's at the college. He came in and was celebrating that he was the lowest paid person on the team now.
Yep.
And he advocated for that because he made his money in the pros. Don't get me wrong, but he was getting paid. I can't remember the number, but I want to say like $22,000 a year.
Yeah, and you would be and the same thing for PT, and sometimes too, a lot of teams will send out for PT. And what's another interesting point too is when an athlete gets hurt, like professional athletes specifically, when they get hurt, that's workers' comp.
Yeah.
Because that is their job. I've had athletes come in before. I know I've had some classmates that have worked with athletes, and
do they get workman's comp, or do their contract just continue?
That's a good question.
Because their contract. I guess it depends on guaranteed money and everything else that comes into it.
Are they insured?
Most athletes are insured, especially
That's where workman's comp is, I think, specific to insurance, right?
Yeah.
So workman's comp is a type of insurance. So when the athlete gets
anything other than insurance games,
because I know a lot of athletes, especially pitchers, they'll insure their arms, knees.
I had a classmate who was she worked down in Houston, and she had a wide receiver in the NFL as one of her patients that. If I said his name, you guys would know exactly who he is. Very well-known wide receiver.
Barry Sanders, obviously.
Oh yeah,
Because he was a receiver and all.
Exactly.
I'm trying to help everyone out here.
Anyway, so he was playing for a team in the Northeast, and he came back to Houston to do his off-season program. And what was interesting is because it's workers' comp, so what a lot of people also don't realize is when you are a medical professional with a workers' comp case, every insurance is a little different, but down in Texas where I worked, if you had a workers' comp case, you'd have to call the insurance every Friday to update them on how your patient was doing. And that's not even just professional.
I could spend 3/4 of your day just doing that.
Yeah. And if you saw a lot of them, that's exactly what you would do. And so it wasn't just, that was anybody. That could have been your construction worker. That could have been anybody like a brewer who's on the job. She'd have to call the actual team every Friday. And what was kind of funny is she called the team. The team was like, how's he doing? She goes, I don't know. And they're like, what do you mean you don't know? It's like, well, he never showed up to therapy this week, so I don't know how he's doing. So that was kind of that's the funny end of it, but the realistic side of it is
in the Northeast. I bet Bill Belichick was mad. That's
not quite that Northeast.
No, okay,
but still.
Can we pry it out of you?
Northeast. It may have been a team that the Chiefs played.
I was gonna say Pittsburgh
this year in the
Baltimore,
the very last game of the season.
Oh, the Bills.
No, the very last game.
The Eagles.
Oh.
Yeah, there we go.
Fun.
Yeah.
There's a lot of teams up in the Northeast. Holy shit.
Yeah, there's a ton.
Okay.
Fuck all that cold weather bullshit.
Man, I didn't even realize that just blew my brain, man.
Yeah,
the
so-
whole workman's comp
Yeah.
for an athlete of an injury like
Yeah.
that. I never even fucked this up.
And-
Does NIL have that aspect to it?
That I don't know, and I think we don't really know yet too, because those athletes are going through the school, so they're technically on school insurance, I would imagine.
Yeah.
Well,
So I don't know,
That's-
because it's not necessarily. I don't think it's workman's comp because it's technically not.
They're not being paid.
Well, yeah,
Are
because
they?
technically NIL is more paid by collective and not the school, so
Yep.
they're on school insurance at that point. So, but then most of those teams, most of the school programs, been like if you're a football player, most major universities have a team doctor on staff that they pay. They have a sports medicine department on staff that they pay. So you're basically just going through that.
And once you're in D1 and stuff, you got to remember you have actual medical schools and actual doctors that are performing real surgeries. But then I would imagine they probably have some, outsourced work with professional athlete doctors. I know a lot of them are making $1 million a surgery.
Yeah, I know when I was doing some fellowship hours down in Dallas, there was a PT I was working with, and there was a football player from the University of Arkansas that happened to have surgery that week I was there, and so I got to talk to him, which is great because going to school there, being a Hog fan, it was awesome to kind of like pick his brain about how the team was, and he ended up needing surgery, so he ended up going down to Dallas to get his surgery because one of his teammates was from the area and had a surgeon there that he liked, so. And again, I think he just went through school insurance at that point to have the procedure done. But, they have team docs on staff, but it usually comes to surgeries. They end up going either outsourcing. And some of the schools, like I know Big Ten schools, to be a Big Ten school, you have to have a medical school. And so they might even go through their own surgical departments there.
I think like the big athletic doctor, the surgeon, I want to say he's out of like Atlanta. One of them. I mean, obviously there's multiple, but I think like the LeBron and all those kind of surgeries, I'm pretty sure he's out of like Atlanta.
Yeah, and then there's also the Andrews Institute that does a lot of surgeries for Dr. Andrews, which a lot of NFL players will go through. And he is based out of Birmingham, Alabama, actually.
Okay.
And so there's a lot of, and I know they have clinics like through the Gulf Coast area.
It's just weird, that I know Atlanta's big, but you're talking Birmingham, Alabama, Atlanta, you would think LA and New York is where all these big doctors would be or something, but it's not.
No, and it's wild too, because I'm pretty sure that Eric Fisher, when he tore his Achilles, I think he went up to Wisconsin actually to have surgery done. I think it was in Milwaukee, actually, at some big surgical center up there.
I thought you were listening to Brett earlier. Doctors just need people.
That's true.
So if you want to go to fuck all Nowhereville, Alabama and be the best, they're going to come to you.
That is true.
If you build it, they will come. And
Yeah.
if you rebuild them, they will come harder. Mm-hmm. Wait.
What?
Wait.
Do you want to rephrase that, or
Nope.
you want to stick with it?
Nope. I'm gonna
Staying
stick
with it?
Okay, stick with it.
Alright.
Fair enough.
All right, Brett, let's talk about how stupid you are. What's wrong
Yeah.
with doctors? Let's talk about that old lefty of yours.
Oh yeah. So as I mentioned, I tore my patellar tendon. Not a fun one. Nice thing is it didn't hurt because it tore completely. So
Good.
I just felt a pop, like they talk about with Achilles tendons, where it's like I felt like somebody kicked the back of my heel. I may or may not have been in a rugby game at, how old was I? 35 years old. Playing amateur rugby.
I played rugby and I did it for about 3 years and realized I was getting old and I quit at like 21. So
Yeah, I kept going. I decided to just stick with it. The fun story, the story I like to tell is that we were, it was a close game. We're down to the final minutes, and I went up to block a kick, and I ended up blocking said kick for us to win the game.
why do I feel like this is bullshit?
Yeah, it's complete
It's
bullshit.
total bullshit.
It's actually completely opposite of all that.
I'm sure it probably wasn't anything cool either. You were probably running by yourself.
No, he tripped on the water table.
Hey, it wasn't that bad. It wasn't that bad. No, we were getting
Fell backwards off the bench.
That would be awful.
We're so mean. We're so mean.
Oh, that would be terrible if that was the case. No, I ended up we were not winning. It was not a very close game. And me being the kind of person that says, let's try to get something going here. Let's get something going here. The guy kicking the extra point or conversion kick in rugby, he sets up really close, and so I'm like, I'm gonna go block this kick because he takes forever to approach the ball. So he comes up, I start running, and I jump and I felt this pop in my knee. And I said, and I'm thinking while I'm in the air, and of course I think I'm really high in the air. All reality, I'm probably not very high in the air. I'm not much of a vertically leaper here. So yeah, I know. And
You're
so
white.
yeah, very. and so I felt this pop.
So white man can't jump.
Not this one. And I'm thinking in my head, man, that tee that he's kicking off of hit my knee. And then as I'm watching the tee and the ball come at me, and I thought in my head, it was all super fast, super instant, right? And I go, holy shit, that wasn't the tee. And I land on the ground and I look at my knee. And like I said earlier, so it's the only thing that covers your femur. And so I could see the groove of my femur through my skin because your femur looks like that.
You got a moose knuckle?
Yeah, right on my knee, And so I'm sitting there looking at it going, oh no, it's a patellar dislocation.
And as a physical therapist, that's got to be the worst because most people are like, something's wrong. And you're like, oh, I know what's wrong.
Well, so that's what's funny is at first I thought, okay, patella, I looked down and said, oh no, that's not right. And again, it didn't hurt. So I'm laying on the ground and thinking, okay, patellar dislocation. We need to straighten the leg and push the kneecap back. And so I'm laying on the ground looking at my teammate and I said, Colton, I need you to straighten my knee and push it back. And he's looking down smiling, just going, no. and all I can think is, you asshole, push it back. Like, I needed this back. And it was funny is the medical person on the sideline was actually ended up being my surgeon. And he comes over to the sideline and he looks at me and he goes, yeah, that's not going to help anyway. And I go, oh no, this is not good. And immediately it goes into, okay, patellar tendon rupture. I'm going to have surgery. And I'm on the sideline and then we're just like, I'm sitting there racking my brain of like, I need to do the X, Y, and Z to get everything ready. And that is a nice thing about having like my background. I was like, I knew what was going on. I never went to shock. It was just more, I was like, I was in awe because I was just more like in disbelief of like, this actually happened. Like you hear about it all the time, especially in our world. Like you hear about this all the time, but you never think it's going to happen to you.
And that's the bad thing too, is you always know as a sports fan, non-contact injuries always end up being the worst.
Oh, they're the worst. I'd much rather have a contact injury because usually like contact injury is like a broken bone and you're just like, which sucks. But at the same time, it's like casting.
Nowadays, 4 weeks later, you're good to go.
Yeah. And at least someone trucked you to get the injury.
Right. You did
Like,
something.
I jumped on my own weight.
And what's funny is, you go into work or you go into everybody else and they tell like, well, you should probably give up rugby, huh? And I'm like, I could have done this at work showing my high schooler how to do a box jump.
Yeah.
Like I do this kind of stuff on a daily basis at work. This could have happened any time.
It really speaks volumes of you as a man.
Thank you.
Speaking of rugby, did you guys have any, how do I want to phrase this? Did you have any traditions after scoring your first try?
At what point in my rugby career? Because yes, we did.
Well, let's just say your club career, not like
what's your
high school or college.
Yes, the first team I played for as a men's club. I will not mention my team, even though I love them to death, just to save face for them. I don't think they do this anymore, and it's kind of the rugby world's kind of changing with traditions after like post match things and all that. But yes, we had what was called the Zulu tradition.
Mm-hmm.
Yeah, I knew.
But how clothed were you when you did the Zulu tradition?
You had shoes.
Oh, okay. Yeah. So it
that
runs.
Was about it.
so the tradition runs through most of the clubs. Then
rugby likes to get naked together.
Yeah. Well, not together, just by yourself.
Yeah, you're usually
in front of everybody.
Funny story is actually I was not by myself for this. Because there was two of us that happened to score on said day, and
nice.
They made us have a race. Luckily, the guy who I was racing against was a forward, and I was a back, and so I was substantially faster than him at the time, and so I won said race, which means I did not have to chug a pitcher of beer.
Well, let's wait to hang you down there.
Exactly. Well, no, not down there.
We already established he's white.
All right. More questions for you here. You said something that brought something to me as we're winding this one down here. You said, I know what's going on with my own injury. Is ignorance bliss?
Can be. I think for me, knowing what had happened was a good thing because I had expectations. Kind of going back to what we talked about, total knees. Some people go in not having expectations. They don't know what to expect, whether it be pain, how they're going to function afterwards. The nice thing for me was I knew what to expect I knew it was going to be a long road, but I knew I can, and I'm still going through some things. This is only, just over a year ago.
Yeah.
I'm still trying to get back to it, but the good news is I know what to expect. I know what the recovery process looks like. So from a medical standpoint, I don't think ignorance is bliss. I think it's better to have knowledge of how the human body works and what it can do. Now, with that being said, there's always a joke that medical professionals make the worst patients, and we really do.
I believe it.
Because we have the power of knowledge. We know what's going on, and so we try to diagnose ourselves. We try to treat ourselves, which doesn't always work.
Yeah.
But to have that expectation of know what to expect you're about to go through, I think it's very beneficial in that sense because it, whether it's good or bad, you know how to approach things. And if you take that with the right attitude, you can make the outcomes either better and you can make your outlook better and enjoy certain aspects of things of life more, in that sense.
All right, let's strip Dr. Bret from medical. Where do you want to be ignorance is bliss? Where would you argue that you find ignorance to be blissful? Or as a whole, do you? I'm curious. It's not.
Yeah,
there's no right. There's no wrong. This isn't a fight.
Yeah, I don't know if I actually do. I think as cliche as it is, I think knowledge is power. Mm-hmm. I think the more knowledge you have about aspects of life, aspects of who you are, how your body works, I think can help you a lot. I think it can hinder you if you let it. So I think it's more again that knowledge, that power of knowledge is key. How you control it and how you utilize it is everything.
Okay.
Well, Ken-Zee, final thought?
My final thought. So what is wrong with doctors is obviously what we're going to ask you as a generic whole. Come back to me, Randy. Come back to me.
You know what? We got to have them. We need them. The insurance process sucks. I'm glad there's doctors out there spending the money to take the risk. Thanks for doing what you do. Thanks for coming in here, man. Appreciate the conversation. I enjoyed it. So,
yeah. All right, we're back. You're a doctor and you work for a company and there's an insurance company that's not your boss, but at a level they are your boss. What would be the one thing that you could change, so to speak, if you could, across your entire profession to make every PT's life better? What's the thing that we're not doing for PTs, or what's the thing that we're not doing in regard to physical therapy that we could be?
Yeah, I think it comes down to, as conceited as this is going to sound, I think it comes down to reimbursement rates for the amount of money that people spend on healthcare and how much healthcare actually truly covers here in the United States. I think that's a big, big thing. And if I could change that, it'd be healthcare would reimburse your physicians, your physical therapists, any other medical, your dentist. I think if it could reimburse them to the level that is fair to said professions, not say more in the sense of like, oh, just give us more money, reimburse them fairly, reimburse them for what they deserve based on how much money you're actually making. Because then what happens is the quality of care should go up. Right. The amount of time your physician, your PT, your dentist, everybody can spend with you goes up, which means your quality of life and health ideally also improves, because now all of a sudden your physicians, your dentists, your physical therapists, whoever else in the healthcare world, they're not stressed out about trying to get more people in. They're now getting reimbursed fairly, and now they're concerned more about the health of their patients, which then leads to a healthier
I do have a quick question on that we did not elaborate with. You said that, they may bill out and the insurance only pays like 30% of what they billed out. So is the doctor eating that 70% or does it go on to the patient for cash?
That's a great question. So what I always encourage people to do is I tell them, go look at their EOB when they get their bill in the mail, or say they have surgery or whatever else, go look at because it'll break it down. And most people just kind of skip over all that. Go look. Mm-hmm. Go look at, if you have surgery or you have a procedure done, go look at how much your physician or somebody bills. Mm-hmm. And a lot of times that number is really high, mostly because they need to get something back. And then go look at what the insurance is actually covering. And then go look at what is left over. And sometimes, yes, it goes upon the patient to cover the last like 30 or it's not usually 70%, but usually it's a pretty high number. Or And then just look at how much your surgeon or physician or physical therapist, how much they're charging, and then how much they're getting reimbursed. And then if you look at that per visit and you see actually how much they're getting reimbursed, now sometimes the patient doesn't cover that, but a lot of times it's just that number is just not paid. So it's sometimes nobody's even covering the cost. It's just lost
It's just
money.
written off.
It's just written off.
So that really dives. Yeah. Again, I question hard. How much could we reimburse people who have sacrificed how many years of school? 7 total or more?
So yeah, most physical therapists are going to do around 7. I did 9 because I did a master's degree, but you don't have to have that. But for PTs, it's 7. Med school, it's what, 8 plus residency.
So minimum of 7, but we've got a dumb, physical therapist here who still plays rugby. So when you really extrapolate it, I'm curious about this insurance savings if we stop paying endorsement deals for your fucking Wheaties box and your ads and everything, and we stopped naming stadiums with insurance money and stopped marketing for something that we have to have, something that if we don't have, we get fucking tax ripped. So it's pretty bonkers to me that they can spend our money in such ludicrous ways and not even take care of the people that are going to school for this and to better other people. So Bret, honestly, thank you for coming in. You have anything final fuckery for us here? I know Randy's taking you down some weird roads. I've taken you down some weird roads. We're here to have some fun, but
no, I just want to thank you guys for having me. This was a blast. And it's fun to kind of talk about some of the real topics that are out there that, that we as medical professionals deal with every day that most people don't realize is a thing. And so it's kind of fun to get out there and finally talk about like, hey, yes, you're fighting your insurance company, but guess what? So are we. And we're like, our goal, no matter what, is we all went to school to get people to become better and healthier. And so, that's what we want. But again, just, thank you guys for having me on. And this was a blast. This was a lot of fun.
Well, you guys heard it here first and last, I guess, but fuck your insurance companies.
Yeah. Tell us what you think. What's wrong with doctors? Like it, share it.
Ooh, we'd love to talk to any insurance company reps who want to come on.
Good luck with that.